So this is a 64-year-old male who had a history of right upper urinary tract hyperurothelial carcinoma as well as urinary serial carcinoma of the bladder. So he has received multiple intravesical chemotherapy as well as the excision of like a right total nephrectomy and ureterectomy. So we know that these patients had multifocal hyperurothelial carcinoma from upper tract to the urinary bladder. And for the upper tract, they already have curative surgery. And for the urinary bladder, they use intravesical chemotherapy. This is a voidy urine specimen. So on low power, it is not very cellular. We do see scatter cells. And then we go to high power. So despite the scan cellularity, we can appreciate that this is inflammatory cell. So this is the normal size nucleus. So you can see these nucleus are all increased with a hyperchromatic nuclear feature and coarse chromatin, as well as increased NC ratio. So these are diagnostic for high-grade urothelial carcinoma. So despite the scan cellularity, we do see diagnostic cells. So this is positive for high-grade urothelial carcinoma. So the next specimen is from an ascites. We've seen this specimen on Friday. This is coming from a 63-year-old female. This is an ascites specimen. She presented at our emergency room with abdominal fullness. So in a postmenopausal woman with abdominal fullness and showing these high-grade adenocarcinoma in the ascites, the first impression for us is that this is likely coming from gynecologic tract. So this is the cell blood preparation. So we see tons of tumor cells. So we just need to help the doctor in the ER to further triage the patient. So this is diffusely positive for PAX8. So you can see the mesothelial cells were negative, the tumor cells were positive. So the patient should be referred to the gynecology department for further treatment. So this is positive for PAX8. So in the report, we will make a comment that this is most likely coming from the gynecologic tract, and the patient should be referred to the gynecology department. So the next specimen is coming from a 65-year-old female. This is a pleura effusion specimen. So the specimen is not very cellular. And the preparation is not optimal because you can appreciate that there are seems to be significant drying artifact. Most of the nucleus show a little bit like a foggy, like a pool fixation type of artifact. So make it a little bit difficult to appreciate whether these cells are true hyperchromatic or not. And it is very difficult to tell whether these cells do have nucleoli or not. And the patient had a history of lung adenocarcinoma. So just by the cytomorphology, because of suboptimal cytopreparation, I think it's kind of difficult to tell whether these individual cells are a true adenocarcinoma cell or just some sort of like artifact. So in this situation, usually we would rely on the immunohistochemistry. So this is the cell block preparation. So again, in this cell block preparation, we do not see frankly cluster of cells suggest that they are adenocarcinoma. But some of the cells do looks a little bit funny. So in this situation, without the immunohistochemistry, we might probably call these a typical. So we do a TTF1. So for TTF1, we do see scatter like cells are like unequivocally positive in the nucleus. So because the patient had a history and is under treatment, so sometimes the treated cancer cell can be a little bit indistinct from the normal cells. So because of the positive immunohistochemistry, we are going to call this case positive for adenocarcinoma. But just based on the cytomorphology, sometimes kind of difficult. So for this case, with the help of TTF1, we will be able to call this positive. So the next specimen is a 57-year-old female. This is a pleural effusion specimen, and she presents to our emergency department. So we received only 12 millimeter specimen. However, we do see scattered gigantic cells with unequivocal nuclear atypia. So I think this cell is definitely malignant. So in this specimen, we do see scattered highly malignant cells. So for this specimen, it is not difficult that we just call this case positive for poorly differentiated carcinoma, because most of these tumor cells show like a very big bizarre nucleus and with multinucleation. And this is a new patient. So for this case, because of the scan cellularity, it is expected that in the cell block, we won't be able to have a lot of cells. So most of the cell doesn't looks too bad. So for this case, I see majority of the cells are in the cytospin preparation, and we won't be able to do immunohistochemistry to confirm anything. So I would just sign this out as positive poorly differentiated carcinoma, and the cell block show no tumor cells. So if the clinician want to know where exactly this tumor is coming from, we would need to have a repeat specimen for further evaluation. So the next specimen is coming from a 69-year-old male. So this is one of the rare scenario in pleural effusion or like a ascites specimen. So old male, this is the pleural effusion specimen. On low power, we do see aggregates of the cell. So the arrangement looks like a cell ball, cannonball type of pattern. So we see tons of these small, tight aggregates of the cell balls. So this seems to be a positive specimen for sure. So if this is in a female patient, the most common type of cancer would be the breast cancer with this cannonball type of pattern. So for the specimen, we see very tight aggregates of the cells, and in the center there seems to be some like a structure. And if we go to the adjacent, like a more flattened area, indeed the cell do show some nuclear atypia with a little bit prominent nucleoli. Yeah, so this does have a nuclear atypia. So comparing to the relatively normal cell, the cell do show relatively irregular nucleus, and some show a prominent nucleoli. So the most common situation is that this is adenocarcinoma, metastatic adenocarcinoma. So the first guess, if this is a male patient, this might be coming from the lung. So this looks like a lung adenocarcinoma with metastases. However, the patient was referred to our hospital from another hospital, and in the primary hospital, the image study show a multiple nodule on the pleura surface. They do not see a primary lung lesion. And in the pleura effusion specimen from the outside hospital, they already do some scan, and then see these cells are mesothelial origin. So this is the cell block preparation of the specimen. So again, these seems to be quite convincing that they are tumor cells in this cell block preparation. Some of the cells do show these tight aggregation, and you can clearly appreciate the nuclear atypia. So usually for the mesothelioma, the nuclear atypia is not that prominent like what we see now. If we want to distinguish between metastatic adenocarcinoma versus a mesothelial tumor, particularly mesothelioma, we will usually use these two stands. The first stand is MOC31, which is a glandular marker. So the aggregates of cells were all negative for MOC31. On the other hand, if we are going to prove it is a mesothelial tumor, mesothelial lesion, we will use creatinine. So the creatinine for these tight aggregates of the cells were diffusely positive. And you can appreciate that in the background, they are actually, these mononuclear, like epithelial cells, are mostly histiocyte, not mesothelial cells. So sometimes very difficult to tell just by cytomorphology whether these are histiocyte or mesothelial cells. However, these abnormal aggregates of the cells were diffusely positive for creatinine. So sometimes we will use more than one mesothelial marker because occasionally the mesothelial cell will show lack of expression in one of the markers. So here we use creatinine. We will also use WT1, sometimes D240. So these were three major mesothelial marker that we will use here. And for the creatinine, we would expect to see a diffuse nuclear and the cytoplasmic expression. So you want to see the nuclear expression as well to make sure that this is a mesothelial origin. So we know that these abnormal aggregates with significant cytologic atypia were mesothelial origin. So some authors suggest that we can make direct diagnosis of mesothelioma just by the cytomorphology. I think for this particular case, it is possible because the clinical impression, the clinical information fit the diagnosis of mesothelioma. Additionally, we do have significant nuclear atypia for these mesothelial cells. But just like what I say, usually for the malignant mesothelioma, you won't see significant nuclear atypia like the current case. So here, if we want to confirm, we will have other more confirmative marker. So here for the mesothelioma, we use three different markers. The first marker is BAP1. So around 50% of the mesothelioma, they would be diffusely BAP1 loss, reflect the BAP1 gene mutation, which is usually the double hit, the two mutation in the BAP1, so resulting in this loss of nuclear expression. So for this case, we clearly see they are loss of nuclear expression of these carotene positive cells, and the architecture pattern is abnormal because it's in aggregates. So with the help of BAP1, the case is diagnostic for malignant mesothelioma. Okay. The other two markers that we use here is one of them is MTAP. So MTAP is a gene located adjacent to CDKN2A, which is the gene encoding for P16. In the situation, occasionally for the P16 loss, they would be called deletion of the MTAP. So somebody will use the marker to suggest that loss of P16. So I think in meningioma, we use that. Sometimes in glioblastoma, we also use that. There were a couple studies for that, but also including mesothelioma. For this case, we do not see loss of expression, so this is not loss. But not loss doesn't suggest that it is benign. It just suggests that for the test, we won't be able to prove that it is positive, it is malignant. So the third marker that we use is Merlin. Merlin is the protein that the gene encoded Merlin is NF2, neurofibromatosis 2. So for the Merlin stand, we want to see a diffusely loss of cytoplasmic as well as membrane pattern. So for this case, we do see like attenuation in the cytoplasm. However, the membranous pattern was still there. So it's kind of equivocal. So for this situation, we would consider this is not definite. But out of the three, we already have one marker positive, which is loss of BAP1. So for this case, we would call this malignant mesothelioma. So this is not very common in our practice, but yeah, this is a good case. So we move to some fundal aspiration. The first is salivary gland aspiration from the parotid. So the background is very clean. We have some aggregates of the cells. So when we go to high power, these aggregates of the cell has a very nice like acinar type of arrangement, and with the nucleus mostly located at the outer ring of the acinar, and the aggregates are very regular. So this is normal acinar glandular cells in the parotid. So we call these non-neoplastic acinar cells. So when we see something like this, if this is the only component that we see in the aspiration, we will call this case non-diagnostic, because possibly the clinician missed the lesion. So usually there is a nodular lesion, a mass lesion, and they do the aspiration. And when they miss it, particularly for the like a deeper lobe lesion, sometimes they will miss it, so they only get these non-neoplastic acinar cells. And how do we make distinction between the non-neoplastic acinar cells versus acinic cell carcinoma? So mostly is the architectural pattern. So for the non-neoplastic acinar cells, you will appreciate that the cellular cluster do have a very nice acinar cell arrangement. It almost looks like a bunch of grapes. And if it is an acinar cell carcinoma, usually you will see a diffuse sheets of relatively bland-looking acinar cells. So these represent acinar cell carcinoma. So usually it is the architectural pattern, not the cytologic pattern, because acinic cell carcinoma have very bland-looking cytologic pattern. So for this case, we will call these non-diagnostic, Milan category 1, and suggest that we only have the non-neoplastic acinar cells. So the next specimen is thyroid finite aspiration. In this specimen, we only have one cluster of cells. That's it. In the direct smear, we also don't have any cells. So this is the only cellular component that we are able to examine. So first of all, if it is a relatively benign follicular cell cluster, usually you will appreciate a more flattened honeycombing type of arrangement, suggests that it is coming from a single layer of macrofollicular. However, for these cellular cluster, you can appreciate that they do have an outer luminal border ring with a more dense, like a three-dimensional core. So this is actually look more like a decapitated papilla, but you just didn't see the blunt end because possibly the blunt end is facing toward us or toward the background. So we can appreciate that for the lining cells, it does show some nuclear atypia, including enlargement, as well as relatively irregular nuclear membrane. So you can see a notch over here, another notch over here. The chromatin pattern is relatively ground glass, and you see a relatively big, like a nucleoli or a chromocenter over here. So based on the morphology, the cell do show significant cytologic atypia, suspicious for papillary thyroid carcinoma. Additionally, the architecture pattern seems to be a little bit abnormal. Although we do not see the nuclear inclusion, I think for this case, we are not able to just call these either non-diagnostic or just benign, because this is definitely abnormal. So for this case, because the presence of both architecture as well as nuclear atypia, we are going to call these as suspicious for papillary thyroid carcinoma. So this is a case suspicious for PTC. So diagnosis of PTC, cytologic diagnosis of PTC usually is not very difficult. But the specimen was compromised with very scant cellularity, so this is the best that we can do. So another thyroid aspiration coming from a 71-year-old female. So in this aspiration specimen, we do have quite some cells in the background. Majority of them were kind of like aggregates with three-dimensional architecture and without the monolayer sheets. We do see some colloid in the background. So when we go to these aggregates of the cells, it is kind of thick, so difficult to see through. But at the outer, like a ring, you can appreciate the cells have a very uniform, rounded morphologic pattern. So just based on morphology, it looks relatively bland looking. There were some scattered like aggregates with similar morphology. So these can be a microfollicle. So something a little bit unusual about this case compared to the benign thyroid aspiration is just like the architectural pattern. It just seems to be 2-3 dimensional. Usually for the benign follicular cell, we would expect to see a flattened sheets of honeycombing monolayer. So then we go to the direct smear. So based on the liquid-based impression, could it be a follicular neoplasm? But when we go to these direct smear, we start to appreciate there are some very complex, delicate, sort of like a papillary type of architecture. So if you see a thyroid aspiration showing this type of pattern, but without any nuclear feature of papillary thyroid carcinoma, you need to think about parathyroid lesion. So again, it is a very delicate, like a branching type of architecture pattern. However, unlike papillary thyroid carcinoma, usually you won't see a very prominent fibrovascular core because this type of pattern is artificial. It's actually reflecting the delicate vascular meshwork instead of the true papillary architecture in the histology. So for this case, we check the clinical history. The patient do have end-stage kidney disease and is currently under hemodialysis. So the clinical scenario fits that it could be a hyperplastic parathyroid gland. So we do GATA3 using the residual liquid-based cytology specimen, and the cells are diffusely positive for GATA3. So this is indeed a parathyroid lesion. And the most likely diagnosis for this case is secondary hyperplasia. So going back to the liquid-based cytology, so we do see colloids, so possibly they do sample a little bit of thyroid component, but just this architecture pattern is relatively uncommon. But I have to say, for the cytological feature, this is basically very indistinguishable from the follicular cell. So sometimes the parathyroid cells looks no difference from the follicular cell, just based on cytomorphology. So architecture pattern is still very important. So this is a EUS-guided aspiration specimen. It is targeted at the intra-abdominal mass, and the localization seems to be at the splenic hilum. So for this specimen, we see a very interesting morphology. It almost looks like a worm or something like that. So we have very spindle cells, and elongated and with rounded head. So this is seems to be a spindle cell lesion. And with this larger fragment, you can easily appreciate that this is a spindle cell lesion with some stroma, and the spindle cells are very elongated. So with the abdominal mass with a hypercellular spindle cell component, relatively bland looking, usually the first diagnosis that we have in mind is GIST, gastrointestinal stromal tumor. So for the case, for this case, in the histology section, it is positive for CD117 as well as DOG1. So the case is actually a GIST. So occasionally we will have EUS-guided biopsy of a stromal lesion instead of adenocarcinoma. So this is the next specimen, pancreatic EUS-guided aspiration. So this is the most common scenario. Around 90% of the cases that we receive is adenocarcinoma. So we can see background tumor necrosis. We can see this glandular architecture with significant cytologic atypia. So again, 3-dimensional. with a little bit of stratification, so it's more like an intestinal type of mucosa and with significant nuclear atypia. So this is diagnostic for adenocarcinoma of the pancreas, and this is the most common scenario. So finally, we have a pap smear coming from a 49-year-old female who had a past history of CIN3 and has received a cone before. So this is the follow-up cytology. So for this case, we do see very scattered cell with these low CO type of feature. So there's one cell, enlarged nucleus, coarse chromatin, and the coelocytic change pattern. So this is a single cells in the specimen. So along the smearing direction, there were a few cells with less prominent nuclear feature. So this is another one. So definitely, I think the patient has a residual infection. Yeah, but the cellularity is relatively low, so we call this case ascus because we only see 2 coelocytes, and there's other cells more indistinct, and the cellularity is very scant, only these 4 dots, and that's it. So we call this ascus. So that's all the case for today. Thank you.